Hello, everyone. Thank you for spending a little bit of your day with us today. I'm very excited to serve as your host for this very important discussion that I know will be equal parts engaging and thought provoking. There have been many consequences by adding a pandemic that is COVID to the long-standing epidemic caused by dangerous prescription drugs such as opioids. One of the most dangerous consequences is the impact on people, both in the working population and beyond, that are managing chronic pain. Welcome to Chronic Pain When an Epidemic and a Pandemic Collide. My name is Carlos Luna, and I work for Risico Total Managed Care, a URAC accredited division of Risico Inc., based in Fresno, California. Risico is a multifaceted organization that provides third party administration services, managed care services, and offers workers' compensation insurance products to thousands of customers throughout the state of California. We are very proud to present this presentation in partnership with our friends at the Institutes of Health, or IOH. IOH specializes in delivering proven solutions in workers' compensation to treat chronic pain, mild to moderate traumatic brain injury, PTSD, sleep problems, and prescription drug addiction. IOH is located in Southern California with locations in San Diego and Riverside. For more information, you can visit institutesofhealth.org. Today, we're joined by a group of very accomplished individuals representing various points of views, ranging from chemical dependency treatment, utilization review, and just about everything in between. Now, they'll have the opportunity to introduce themselves here momentarily, but for now, I want to hand the time over to our moderator for the day, the Southern Region's Mr. Fantastic. Ladies and gentlemen, please give a very warm welcome to Mr. Mark, the RX Professor Pugh. Mark?
Wow, thanks, Carlos. I don't think I've ever had an introduction like that, but I appreciate that. I am Atlanta, so that's the southern region of the United States as opposed to the southern region of California. I'm very excited to be a part with this very esteemed panel. I'm with Preferred Medical, a pharmacy benefit manager and ancillary service provider, but I've been around in work comp for about 30 years and really been thinking and talking and writing about the overuse of prescription opioids and other ways of treating chronic pain. And so when you think about epidemic, which certainly is around the opioids, benzodiazepines, and other painkillers, and you think about the pandemic, which is why we're doing this as opposed to in person, and why in the perfect 13th month of 2020, one of our panelists has to join us via phone call because the app wouldn't download on the computer. This is the typical kind of microcosm of what we've all been living through and with, which is a lot of mental health challenges, just to kind of the status quo of what we've been anticipating that would happen every day of our lives. And when you think about injured workers specifically, or other people that are in pain, especially chronic pain, their access to care, their access to options for treatment of care, and all the psychosocial that comes along with dealing with just the pain that's in their body, but also the emotional and relational pain of being isolated, sheltered in place, of having kids at home trying to probably not doing great job at that, trying to deal with their employment, that their job may not be there. There's a lot of stuff that's going on in everybody's life, and that has an impact on that. And that's where we've talked about and read about a lot about deaths of despair, the increased calls to suicide hotlines, the increased use of substance abuse, and all the variety of things that come from that. So what we're going to do, we're going to try to pair the epidemic, which has been ongoing for since the mid 1990s, of the overprescribing of opioids and other painkillers, pandemic that looks to be maybe close to an end, but we've said that for the past year. I don't know about you guys, but I am up on my 1 year anniversary of my last business trip. And so that was short before we talked about 2 weeks to flatten the curve. And here we're about a year later, and we're still in the midst of it. So when you factor all that into account, there's a lot of things that are going on in the minds and in the lives of injured workers. We want to talk about that. So rather than trying to introduce our esteemed panel on their behalf, I would rather allow them to take 2 minutes to talk about who they are and especially one thing that has most concern COVID as they have been learning and living through this. So, Lisa, let's start with you. Your 2 minutes platform on who you are and what's concerning with you about COVID.
My name is Lisa Fitzpatrick, and I'm the owner of Excellable. I'm also an occupational therapist, and I have a post-professional occupational therapy degree with a focus on injury management. And we really work with a lot of our clients in helping them regain function. And I'm going to talk a little bit about that today. I think one of the things that really concerns me about COVID, and I had this relationship with one of my colleagues yesterday, is the after effect of COVID and what's going to happen with all of these people with some type of chronic issues that are going to arise as a result of what's happened in the pandemic. And I truly think that we have not seen the brunt of this yet. I think that due to the stress and due to the things that have occurred in this past year, we're going to see a significant number of issues arise where people are really going to have difficulty with whether it be functioning with their day-to-day situations and the carrying out their daily tasks because of some chronic illness or chronic disease that has arisen. Just very briefly, I don't share this frequently, but I, for the past 7 years, have been suffering from a chronic illness myself and have firsthand experience in what it's like to have to deal with the day-to-day stresses of trying to work and trying to run a business and really trying to grasp what's going to occur day after day. And so I can empathize a lot with the people who are suffering from COVID and really what's going to happen next and how we can help them minimize the stress and help them see that there is a path forward, I think is going to be key.
Great. Thank you, Lisa. Brooke.
Hi, everyone. My name is Brooke Ferrick. I'm an independent nurse case manager in San Diego. I've been a nurse for 33 years. I don't like to say that. I'm also a life care planner in the med-legal arena. I am the president of Rehabilitation Nurse Coordinators Network, which is a group of case managers who meets in San Diego quarterly. Sadly, we're meeting virtually now. We miss our networking opportunities. But as a case manager, I think I can bring a unique perspective to the call. So I'm looking forward to the different power talking points that we have together. My biggest concern is the fear that I'm seeing in my patients. There's a lot of fear or lack of control. So we'll talk more about that as we move forward. Thank you, Mark.
Thanks, Brooke. Lack of control, certainly everybody, I think, can empathize with that for sure. Dr. Clark Smith joining us via phone. If you would take a couple of minutes and introduce yourself and describe what you're most concerned about by COVID.
Yes, thank you. I am the medical director at Institutes of Health, and it's a very interesting clinic. We deal with chronic pain syndrome, but also with post-traumatic stress disorder and brain injury, and many of our patients have all three. I started off in pain medicine about 10 years ago, and originally was in forensic psychiatry and also addiction medicine. I started off in internal medicine and worked as an emergency room doctor before I got into psychiatry, so I've been able to use all of these areas. The thing that I've seen the most concerns me is the long haul COVID syndrome. I've seen a couple of cases, and basically it's an autoimmune disorder with vasculitis, and the patients have symptoms that are almost consistent with brain injury, memory loss, and problems with cognitive function.
Thank you, Dr. Smith. And that long hauler, Lisa touched on that as well. You know, the issue of this being a novel coronavirus and only necessarily being, 12 to 14 to 15 months into it is we haven't been at it long enough to really understand what the long-term repercussions are. So that certainly is something that is unknown at this point. And finally, but certainly not least, Dr. Gart, if you could introduce yourself as well.
Okay. Thanks, Mark. My name is Avram Gart. I'm the medical director also at Risico Managed Care. And my background is in physical medicine and rehab with a pain fellowship at UCLA. I'm primarily focused on UR, utilization review. And over the last year. Naturally, we've also seen claims and UR requests for COVID-related illnesses. Long haul syndrome certainly is manifest in different manner. We'll probably tackle that later in the discussion. In terms of opiate use, we've had to apply our guidelines to individuals that have used opiates on a long-term basis, maybe supplementing their issue with COVID in general, and trying to be fairly sensitive to both doctors and the injured workers in that regard. Naturally, we're dealing with telemedicine right now, and also difficulty getting elective surgeries done in a timely fashion. So the patients are having to deal with chronic pain issues longer than they'd like to. So it does create some hurdles to get over. And again, from a UR reviewer perspective, we have to be more sensitive in that regard.
Thank you, Dr. Gart. I think you've already seen value from the panel already as they talk about their specific perspectives and kind of their experience with COVID, but we're just getting started. And so we're going to do this in a fairly quick manner. Everybody's going to get 3 minutes to respond, and I actually got a timer. So if you see me start doing this, you know that you're getting close to the end. But the way we decided to do this, because we do have 4 different perspectives, 4 different disciplines, and 4 different kind of insights into what the epidemic and the pandemic have been doing, we decided to break it up into how to manage chronic pain, what was happening before COVID, what is happening during COVID, and what they anticipate will happen post-COVID, if there is ever such a thing. So we wanted to start off with managing chronic pain before COVID happened, when we all could be in the same room together, whether it be at a conference or whether it be at a doctor's office, in order to kind of manage this particular process. So Dr. Smith, I want to pose this question to you. Are prescription opioids appropriate for chronic pain? And I know that probably hasn't changed a whole lot from pre-COVID to during COVID to post-COVID, but if you can give us your perspective.
Yes, I think this is one of the biggest problems in pain medicine. At the turn of the last century, the theory was no one should be in pain, they just weren't getting enough drug. It was also called no ceiling. In other words, there's no upper limit in how much pain med could be prescribed. And when I started off in the field, I had many patients on horrible doses of fentanyl, and I was constantly trying to cut them back and reduce the amount of drug they were getting. Also saw a lot of what's called opiate-induced hyperalgesia, which means basically the pain receptors reset and there's hypersensitivity to pain that actually makes it a lot worse. I think if I have an appendectomy tomorrow, I want to get opiate pain meds for a short time, but for a long time, the opiate pain meds actually can make the problem worse. Now, when you throw in the complications of telemedicine, then that requires a lot of limit setting with patients, and they need to understand that I care about them, but I'm not going to give them all the drug that they want.
Gotcha. Thank you. So have you seen an increase in the use of opioids or prescription painkillers since COVID started?
What I've seen is because there's not the face-to-face interaction, that often it's just easier to keep patients on the same prescription over and over because it requires a lot more effort and interaction to cut them back. So I don't think there's necessarily more, but I think there's a risk of meds being continued long after they should be tapered and discontinued.
Yeah, I would agree with that, Mark. From a UR standpoint, we're seeing longer term use of opioid medications that normally would be addressed by pain physicians with some type of intervention, physical therapy, an epidural injection, and opiate weaning. So the prolongation of use of opioids is an issue right now during COVID, where pre-COVID it wasn't that much of a problem. So that's the main type of hurdle that we have to deal with when we're doing UR. And I would agree with Dr. Smith regarding the use of opioids. Certainly, I think what has come to be realized is also the importance of cognitive behavioral therapy and psychology here. Any type of treatment that can give support to the injured worker, especially now during the COVID crisis. And a lot of these treatments, especially psych, can be done via telehealth and over the telephone. And something that I've learned is that the importance of cognitive behavioral therapy as a supplement to really support these patients at this time has really been invaluable. So, from a UR perspective, again, we try to support the injured worker as much as possible, and really try not to push the discontinuation of their medications unless they're really able to re-engage the treating physician and come in and have a conversation regarding their drug regimen, and hopefully get back on track with regard to their total care.
Yeah, Brooke, from a case management standpoint, do you see kind of the same thing that Dr. Smith and Dr. Gart have talked about in regards to the continuation of painkillers in maybe an inappropriate situation has actually increased during this time?
I would agree with what they're saying. That's what I'm seeing, and just the value in case management, if we can get on that call, would be to help reinforce what the physician is saying. So, and we can also inform the physician what the patient is doing. So, the idea of having a case manager navigate the appointment and to get in there with the physician via on Zoom. We do go to a lot of doctor's appointments as well. We are in the office. Sometimes we're excluded, most oftenly in the acute care setting, but we are included. And to what we are seeing is exactly what the physicians are talking about. But having, in terms of how is case management add value, that's the piece, is closing the circle, because they're with the physician sometimes 10, 20, 30 minutes. Then when they go home, that's all they have of that. And if the case manager is looped in to that initial piece, the most important thing is to, you can say, well, remember, doctor said this. Remember that he wanted you to try and use 2 a day instead of your typical 4 a day. Have you done that? So it's the follow through, and you bring that back to the physician and say, I know you directed them to do this. They've done a really good job weaning that down. And then the physician has other options. Or you can say, I'm sorry, their support systems are not in place. And you can work with them as a team to try and get that back. And then you take that back to the carrier to say, look, I'm in there, I'm boots on the ground, I'm with the client, I'm with the doctor. As a team, this is our plan. He can or he can't do it. So case management is really vital, especially now when there's not a lot of hands-on. They really, my patient load, they're very thankful that we're involved. It's rare now that I have a patient who doesn't want a case manager, because they really need that. We're kind of closing the circle on the overall team approach of the pain management.
Dr. Smith, have you seen a difference in compliance before COVID and during COVID in regards to treatment regimen?
I haven't, because we've been able to convert to telemedicine, and we use biometric monitoring. I think the first 2 months patients were a bit uncomfortable with it, but I think we've been able to make good connection and keep people really compliant.
Speaking of compliance, physical therapy, occupational therapy are certainly disciplines that you can do at the office, but you may not do it when you get home, even though the practitioners give you the experience with that. Lisa, what have you seen in regards to pre-COVID and how you created and applied physical and occupational therapy to what it has morphed into related to COVID?
Thank you for the question. I think physical therapy and occupational therapy play a critical part of the team. Um, Really, I feel that we're of benefit is we have more of that one-on-one time with the clients and really being able to spend time with them and find out, kind of getting a little bit deeper, if you will, on what's going on at home, what's going on with their daily activities, helping them regain function. I really feel pre-COVID, we kind of got used to the going to therapy, doing the exercises, going home, sometimes not following up on the exercises, really not being as vulnerable as a clinician with our patients in helping them understand that, we are there, we empathize with them, but helping them recognize that it's okay to be scared, to be fearful, to have pain, to be stressed out, and then really helping to apply the proper tools and resources to these patients to help them regain our function. I feel that therapy's approach is really focusing on people to help to regain function, help them get back to their daily activities. And we're more or less a facilitator of resilience, if you will, where there's helping people adapt to their environment and modifying what we can modify. I feel that that isn't always applied in the therapy field as much as I would like to see, or it's not always recognized. And I feel that the therapists play a critical part in that if they're able to employ that with their patients.
Gotcha.
Hey, Mark, can we pause for just a quick second? I have an audience member question for you guys.
Absolutely.
And the question is, have there been an increase in supplementing opioid use with other substances such as alcohol or NSAIDs during the epidemic? A follow-up question to that is, have there been any problems with obtaining toxicology to verify the clinical dosages during this time as well?
I can take that. Dr. Smith here. Nationwide, there's been a much higher incidence of drug and alcohol use and overdose during the COVID lockdown. So, it's definitely a factor, and it goes along with the issues of deaths of despair that Mark mentioned. As far as getting toxicology screens, we've done mail-out toxicology screens. And of course, the biggest downfall with that is we're not there to monitor, who's putting the urine into the box and mailing it off. But we interestingly have caught patients using other substances at about the same rate. So I think you can make it work, but the problem is people self-medicating with drugs and alcohol. Of course, that's antithetical to any positive gain you might get from treatment.
Dr. Gard, I'm assuming evidence-based medicine does not recommend combining alcohol with prescription opioids or Xanax. Would that be an accurate assumption?
Yes, sir. Yes. No opiate use with benzos or alcohol. And I would say that has been an issue because of the concurrent psych problems that people are experiencing, both in and out of work. And sometimes patients with an orthopedic type work injury are treated outside of work through their okay, thank you. All right. My daughter's here, and she is telling me not to say She's listening. Don't say
Oh, wow. Okay.
Saying it too much.
Saying it too much. Okay. Go back. Thank you very much. Good input.
My wife does the same thing. We need constructive criticism like that every once in a while. Absolutely.
All right. I don't want to encourage her too much, otherwise she won't stop.
I just want to say that is the highlight so far of this webinar right there. So
Okay. Well, we can ask her to come back. She's very entertaining. All right. Where was I before we were interrupted?
Something about not mixing alcohol with the rest of the stuff.
Right. So, the bottom line is that a lot of patients have high anxiety right now and are treated for anxiety and depression through their private doctors. And the work related injury and the physician treating that injury needs to get on board just because of that fact of concurrent use of benzos or some psych drugs that they don't really know about. So I think checking cures in California or any kind of a drug listing that or a state query is very important in these times, especially, and to be aware of the concurrent use of benzos through a psychiatrist or a family physician and pain medication.
And Dr.
Absolutely.
Gart, Dr. Smith here.
Yes.
Yeah, I really agree with that. Depression and anxiety really are major problems now. All of my patients are stressed out. In fact, all of my neighbors and friends are stressed out. And recognizing that and being able to treat it is something that is really helpful at our clinic at IOH. We have great psychologists that do CBT, and I am treating a lot of patients for their depression and anxiety, which of course makes their pain worse.
Well, I guess if there's a silver lining of anything in relation to the timing of COVID, number one, we had the technological infrastructure to be able to do these kind of things virtually that we didn't have 15, 20 years ago. And from a work comp standpoint, I think work comp is much more accepting of the biopsychosocial treatment model than it has been historically. And so when you're talking about all the things we're talking about, if this had been 20 years ago, most of the work comp industry would have been running away screaming with the concept of psych as a compensable diagnosis. Brooke, when you're talking from a case management standpoint, I'm sure you're using different variants of cognitive behavioral therapy, motivational interviewing, different techniques to help them uncover what's going on with that. How does that discussion translate sometimes when you're dealing with them after they have visited the doctor?
Back to my comment about control. I feel like it does give them a little control if your interview technique is such that, tell me how you thought it went. What did you hear from the doctor? And what did you think of when the doctor said this? What is your plan going forward to implement what the doctor said? So by to them on a regular basis, giving them someone they can talk to readily and easily, it allows them a pathway to address their concerns, control over what they want said or treated or done. There is a lot of depression. We see it. There's a lot of anxiety, just a lot of anxiety. And by helping them their physician appointments by saying, okay, what is it you want to talk about today? You can separate COVID from the chronic pain issue. You can say, okay, thankfully you don't have it, or if you have it, you can deal with that. But then say, okay, let's talk about your injury and pain. I've a lot of patients trying to meld that together and just say, look, I'm so anxious because of COVID and my pain, and it becomes a great big ball of anxiety, all related. And my goal as a case manager is to separate that out and say, yes, we're all anxious, it's terrible. Talk till that pathway ends, and then go back over to the injury. Okay, so tell me how you are now versus last month. How did your therapies work? Were the medications effective? I find that if I'm to separate and refocus on the injury, we have a much more productive physician meeting. And it's the practice of most case managers. We're usually in a waiting room sitting with the patients, kind of debriefing before the appointment. And then we talk afterwards as we walk to our cars. But more than that, it's now, I always try and make a point to call my patient ahead of time and debrief that way. Get them off the COVID machine and get them back onto the work injury. Let's be very objective about how things have been going and what we're seeing. this is what we can tell the doctor, then he or she will be able to give us a plan moving forward.
Gotcha. Lisa, you have a unique perspective because you have the ultimate biomedical approach of physical and occupational therapy. It's really a hands-on kind of thing. But as you mentioned in your intro, you've had your own journey in relation to chronic pain. How does the psychosocial component that we've been talking about, how does that affect the physical function, not only now, but trying to regain the function that they may have lost?
So I think it's a critical piece that's not always addressed in the therapy field. When we look at somebody who has severe anxiety, we take that initial exacerbating moment and we call that the fight or flight response. Your autonomic nervous system kind of kicks in, your blood pressure increases, your heart rate increases, you have a release of cortisol and epinephrine. And sometimes people get stuck in that fight or flight mode and they get to the point where their body is exhausted. And they call that the exhaustion phase from that fight or flight mode. And I think it's important for therapists to recognize that there are times when people have a chronic illness like myself or have chronic pain that doesn't always show up in diagnostic testing, but that doesn't mean that their pain is not real. It doesn't mean that they're not having symptoms. I think as medical professionals, we need to sometimes look outside of our box of what we're used to seeing and start treating the root cause of the problem. Go back to that exacerbating event, such as in COVID, and finding out how can we help with decreasing their anxiety, decreasing the stress that's exhibited. And we're able to do that from a therapy perspective.
Gotcha. Dr. Smith, you had mentioned a little bit ago in regards to telemedicine, telehealth, and your switch at IOH and how to do that, biometrics and a variety of things. Can you kind of describe how you have adapted as an individual clinician and as a clinic, as a facility in offering this kind of care in a virtual manner?
Yeah. At first, it was sheer terror. The whole country was shut down. We were not doing any in-person appointments, and we just made this huge technological leap. We distributed iPads to our patients and hired information technology staff and switched over to telemedicine along with biometric monitoring, which is basically like a Apple smartwatch. And we can track sleep with that. We can track the ability for people to reduce their pulse rates and in relaxation techniques. And you know, it actually was at first it was terrifying, and then it was just difficult. And now I think it seems to be very natural. Patients and therapists alike have adapted to looking through the screen and connecting with people in a real way, and making things happen to help our patients.
I have opined on several occasions over the past year that I think the relaxation of regulations around telemedicine are here to stay because consumers are going to expect the convenience and providers are getting used to the scalability, the increase in scalability. Dr. Gart, what do you think, based on your perspective, what do you see as the next step in regards to telemedicine? Is it going to go back to how it was pre-COVID? Have we learned some stuff through this process? What's your thoughts on the whole telehealth model?
I think that patients, as well as physicians, are getting more comfortable with telemedicine, obviously. I think a lot of patients would prefer not having to come in to see the doctor every month. I think that, chronic management, especially with patients that are stable, can be done over the phone. Interestingly, we've also seen, at the height of the pandemic, when, providers such as physical and occupational therapists weren't really seeing patients hands-on, there was something called the Tele Rehab that was invoked. And that was actually very important to just maintain a connection between the injured worker and the therapist. Even though they weren't coming in, or the actual office visits were spaced out, a lot of the follow-ups were done via telehealth or tele rehab. And this was very important in terms of, promoting the patient's rehabilitation. So I think moving forward, we're absolutely going to see an increase in telemedicine, both in the therapeutic, realm, especially with the psychology and cognitive behavioral therapy treatment, which is a natural and much easier, obviously, to carry out, as well as a little less hands-on treatment and follow-up via telephone and video. A lot of the doctors also are getting better at doing video exams, although there's no replacement for actual hands-on examination. But I think moving forward, there's definitely going to be a lot of integration with IT and vital signs that can be taken by the patient in their home and then sent in, blood pressures, things like that, that don't absolutely have to be done in the office, that can be done at home and supplemented with a telehealth visit.
Yeah, Brooke, I know you're anxious to talk about access to telehealth, especially in situations where the injured worker or the patient may not have access to a smartphone, iPad, out in the field, agriculture, et cetera. How do you deal with that from a case management to kind of bridge that gap?
Yeah, Jill Dulich asked that question. How do you handle the injured worker that does not have access to telehealth? Believe me, a lot of people don't. And, I work with a lot of patients in Coachella Valley, El Centro, Brawley, that even here in San Diego, actually, that absolutely just don't have the capability, even on their phones. And I have doctors' offices sometimes, well, kind of frequently not getting that. They'll say, well, just do this. But you've got the cultural divide, you've got a language divide many times, and then you have the technology divide. Sometimes they don't have Wi-Fi. So what I do is, if I can, I will go to their home and bring my laptop and work with them on that. We do. Of course, that's a case manager role. If the patient doesn't have a case manager, you're stuck. I also have seen that we just have to do telephonic. And sometimes the way telephonic calls work, I'll call the provider. This happens to me a lot with pain management or even psychiatry or psychology, where you call me, I'll call the patient, because if the patient doesn't recognize the number or doesn't trust getting a call from that number, they're reluctant to answer. So what I will typically do is loop the patient in first and let the provider know that we're there and we're ready. And that three-way telephone connection also works. It's very hard for some of them. Of course, they're also very remote. So you're saving them a 2-hour each way trip sometimes. So we've got injured workers in El Centro treating in San Diego or Long Beach or Riverside. So they like it, but at the same time, they have difficulty with it. And telephonic obviously is not ideal. Physicians or providers want to have eyes on. But if you can do it, and that's how I get around that. Either a 3-way call or I go to the client's home with my laptop and facilitate it. That's just the best way that I have found, because there's no way around that a lot of times, direct physician to client. And you really have to pull the provider in to get them to trust that you're going to be able to handle that, because they get nervous. There's also a billing thing. I don't quite understand the billing on the physician side, where you can bill but a phone call is a different, I don't understand it, but I have heard from some of my providers that it's harder to bill the telephone call versus the telehealth visit. But I think that's being worked on. And I think a lot of the providers are working on the billing, and it's become much more streamlined, because before it just wasn't an option. So it's both exciting and challenging.
Yeah, well, one of the things fairly early on last year, the Centers for Medicare and Medicaid Services opened up telehealth greatly, and in access associated with that. And one of the things was that they said that that doctors should be paid for the same fee, whether it was in person or telehealth, in order to try to encourage that kind of treatment. So in Medicare. I don't know what the new administration's position is on it, but the past administration didn't see any reason to back off of Medicare and take that off the table in regards to that. It looks like there's Lisa back again. Speaking of Wi-Fi and internet access, Dr. Gart mentioned the Tele Rehab, and I have seen some software that does Tele Rehab, and it's really cool technology to be able to measure range of motion, has a lot of communication back and forth, video recording, audio recording of stuff. From a physical therapy and occupational therapy standpoint, since we're kind of on telehealth, can you talk in terms of what Tele Rehab looks like and what the prospects are going forward?
I agree. I think that Tele Rehab is here to stay. I feel that it's really important because it's helping clients stay engaged, not just the 2 to 3 times a week they're coming into the clinic and doing therapy, but it's allowing them to stay engaged throughout the process. So if they need to be exercising or stretching, they have the ability to do that with their program 5 days a week. There are Tele Rehab programs that allow for that with stretching protocols or strengthening protocols. I also think that there's a big piece in the prevention side. I know one of the things that we have really spent the pandemic building is a platform where we do a lot of preventative education on how to reduce chronic pain, how to set up your office properly, all of those types of things really help people that are having any type of issue. But again, I think there's a Tele Rehab is something that's going to continue as being a primary service that is offered.
Well, necessity is the mother of invention, and COVID has been the mother of a bunch of stuff, including invention when it comes to this. A quick question to Brooke and kind of follow up from Stephanie Brogdon. From a case management standpoint, do you feel that facilitating return to work is more challenging than pre-COVID, especially with frontline workers or first responders who sustain injuries that are non-COVID related?
It's definitely more challenging because it seems like when you go to the provider's office, you then have it's a step forward, if you will, or if it's a step toward treatment that'll move you forward. And sometimes the telemedicine doesn't allow, but I think the case managers need to be on those calls with providers, and most providers have been great about allowing us to loop in and just make sure those questions are asked. Make sure make sure you prep ahead of time, like I said, with the client and what are our goals for this visit. And secondly, saying, okay, doctor or whatever the provider is, a PA or whatever, say, how are we doing in terms of, these are the work restrictions. Did you get that job description I sent you? So I say, my response to that is I don't change my practice. How I do it is different. We have to get them the job description. We have to get them the physical capabilities, the therapist notes. This is what this client is doing now. There is modified duty available, doctor. What do you think? So that piece of it hasn't changed. How you present it is definitely different. You have to make sure if you're faxing or emailing, you call before that visit and make sure they receive those notes, receive that information, and they've had a chance to review it ahead of time. So it's a little more work on the phone and who you're connecting with. And I had to say, sorry, doctor, I did fax that over to Jerry. She said she got it. And he'll say, well, hold on, and come back. Yeah, Jerry just gave it to me. So you have to be ready for what you have. And make sure that, you're not looking like you're shoving that injured worker back to work, but you talk to them ahead of time and say, these are the goals for this appointment. Let's see what the physician says about you getting to work in some form of modified capacity. But you got to keep it on the forefront because these things are going to drop below the line of focus if you don't on
it. That's great. And I think, the best practice and standard of care really doesn't change is the amount of effort required to connect the dots because you're not in person with a bunch of people.
Hey, Mark. So the next question is from Jill Dulich. She's asking a follow-up question from Brooke. So as a follow-up to her initial question about telehealth access, how does this work in cultures where hands-on is so critical to successful treatment and improvement in return to work?
Right. And I know exactly what you're talking about, Jill. I think that I have home visits with the client, I'll go. I'm vaccinated. I think it's really important to make sure you protect yourself as well and do all of your PPE and get all of that handled. I think that my idea is that I go with them to the house, and then also I try to find a local provider that they can see. Maybe not their primary treating physician, just somebody else who we can get into, because there are a lot of local clinics that see patients, and they're doing it their own way. Until you're called, you come in by yourself. Because if you can identify, you're absolutely right, that hands-on component is critical. My farm workers, the people in the valley, and the people that are isolated geographically, that's my answer to that. I find a local clinic that we can get them to. I know it's a long trip for me. A lot of times the carrier is reluctant to pay that travel and time, but I think it's critical in a lot of these cases. So that's a really good question. Not always critical, but in these cases where culturally hands-on is extremely important, I think that's my answer to that. I'm finding local clinics that are going to see these people, and I know most of them recommend certain clinics, and I know most case managers are familiar with the good OCMED clinics that you can get patients into.
Welcome, Dr. Smith's face to the panel just in time for a question for you. And this is a question I'm going to ask each of our panelists. What have you learned during COVID that will help once it's gone? And again, I'm going to put gone in air quotes, assuming that at some point we're post-COVID. But what have you learned that you think will help?
Yes, I think the ability to reach out to a much broader patient population. I have 3 subspecialties, and I can't travel everywhere in even Southern California, much less the whole state. But through telemedicine, I can reach out to people and supervise nurse practitioners that are in different cities, et cetera. I think that's going to be something that will help people in the long run, and I think improve services.
Gotcha. So it gives you more access to more patients, which yields kind of that scalability. Have you seen an increase in use or desire for use of the 3 subspecialties that you have that you can actually deploy now when everything was in person?
Yes, well, particularly our PTSD intensive outpatient program. We've been able to use that, as Dr. Gart said. It really is amenable to telemedicine. We hired a guy who ran PTSD programs at 3 different VAs, all through telemedicine. So he was already experienced with that. Many of our patients prefer that because they're intimidated and they're afraid to leave their house, et cetera. And it makes it easier for them to engage at the beginning.
Gotcha. Great. Dr. Gart, what have you learned during COVID, either from a utilization review or your practice, that will help you think once COVID is gone?
Pretty much the same topic that we've been talking about is that telehealth is very important and here to stay. Before COVID, I never did any telehealth myself. Never. I didn't think about it. And now, pretty much exclusively, I'm doing telehealth, on a regular basis. And my patients enjoy it; they like it, and I think for me, it cuts down time, it cuts down travel, and as Dr. Smith said, it's easier to engage a broader range of patients right now than we would have without the telehealth. Applying utilization review to a telehealth visit is more challenging, I think, because you don't have the advantage of a hands-on physical exam to apply to the actual guidelines that require certain criteria that necessitate a medical request to be authorized. So it's more challenging in that regard. Less so for, I think, obviously CBT and psych, again, it lends itself a little more readily to telemedicine. I think the most interesting thing that we discussed is the application of Tele Rehab and different types of software that's coming out now to promote that, to again continue to engage the patients, whereas before we had this as an option, patients would be on their own to do their own exercise and to carry out everything, just in isolation, so to speak. So I think the telehealth and the telemedicine, telerehab, is the take-home message for us, at least in terms of what we learned and what we can see moving forward post COVID.
Yes, Dr. Smith.
Yes, thank you. I think we'll be doing a hybrid where, especially with the first evaluation, we'll have people come in person. And right now, using PPE and testing while the virus is still raging on. But as soon as possible, I want to be able to at least do that initial evaluation, hands-on physical exams, evaluations with physical therapists, et cetera. And then I think once you've made the connection and the patient trusts who you are and that you want to help, then I think you can do it with telemedicine and do it better.
Gotcha. Thank you. Brooke, same question to you. What have you learned during COVID that will help once it is gone?
Yeah, I'm going to lean on Dr. Smith there. I think that the telehealth thing is going to reduce costs in the long run, provide people that are carriers that are paying us as case managers. I think that as long as we adapt our strategies to make sure we're able to meet with the client ahead of time and then address these things in the meeting. But aside from that, just the finesse of it about being able to the client, I think learned that you have to be a little more astute, and you're not only relying on these visual clues, you really have to listen to what's being said and probe to get them to say what's really in mind. Because a lot of times you can see visual clues when you're meeting with them in person. And Felicia asked a question that's kind of just more of a comment about a lot of these people are working remotely. So how do you return to work when you're saying, okay to go back and sit in front of your computer? So, there's those types of things that a lot of people will probably continue working remotely. A lot of businesses have decided that that's okay. Maybe not teachers like in Felicia's case, but I think that we're redefining as we go, and I'm learning something every single visit. Honestly, I am. But more than anything else, what I'm seeing is the patients really needing to. You got to listen and pay attention on what's going on. Thank you, Mark.
Listening is certainly a skill and a talent, and maybe needs to be more developed through that. Because you're right, there is no nonverbal communication unless you've got them on the phone, a visual phone. Lisa, what have you learned during COVID that will help once it's gone?
I agree with all of our panelists here. I definitely think that telemedicine, telerehab is here to stay. I also agree in the listening aspect is very important. In regards to Felicia's question with return to work, I think that's a lot of fear right now with employees, not only from the children going back to work, but the fear of getting COVID. And I really think from a medical professional standpoint, for all of us, it's really helping and kind of being that guide and letting people know that they're getting back to a safe area. Going back to the telerehab part, I think what we're able to do through telerehab is really being able to collaborate with other medical professionals, but also kind of be that constant eye and ear for that patient, where we weren't able to necessarily do that before because they're only coming in 2 to 3 times a week. Now we can kind of have that direct interaction with the patient and report back to the treating physician, the case manager, the claims examiner on what's happening with the patient and that they might need some extra assistance through cognitive behavioral therapy or there's severe anxiety or something like that. So I agree with all the panelists.
Gotcha. Well, it's we have a consensus. Telehealth is probably the best thing. The adoption and the use of it is probably the best thing that comes from COVID. There is a question from Darcy. Is there data to show the success of patients who are able to taper opioids, polypharmacy, and return to work since the start of COVID and telehealth? And I think that the statistics that bear out the value of telehealth is going to be probably the prominent way of determining how long telehealth is going to be with us. Because if we find that the outcomes are significantly worse with telehealth versus in person, telehealth will go the way of the mastodon. But I don't think that's going to be the case. I think, we're going to find that it's at least as good, if probably not better, for all the reasons the panelists have talked about. So Dr. Smith, Dr. Gart, do y'all have any insights on, the success rates that you've seen, hearing anecdotally what you anticipate?
I don't think there's any statistics yet, Dr. Smith, that I've seen anyway. It's too soon. And I think everybody's going to be looking at this and trying to determine, if in fact the stats are better, worse, or the same. From what I see, I think people are tending not to wean and get patients off of medications during this time. There's just too much going on, and it's very difficult, at least right now, until people get used to telehealth, to really invoke an aggressive weaning program. And a lot of weaning really is a multifactorial, and it depends also on engaging the patient, and sometimes face to face is important. However, as we move along the telehealth road, I think we're going to see more weaning and opiate detox through these means rather than having to come in.
And we do have stats at IOH in terms of progress with our PTSD patients, our brain injury patients, because we do serial testing and can document their progress. As far as weaning, I'm still doing it, but if I have the support of the intensive outpatient program with cognitive behavioral therapy, and it makes it actually doable and really indistinguishable from in person. Without that additional support, though, I agree with Dr. Gard, it's hard to do.
Gotcha. Well, one final question. We're coming up to the top of the hour from Jill. Has there been a greater impact on another Jill? Hey, Jill. Hey, Jill. Has there been a greater impact to older people who are not tech savvy and may not be able to navigate software, which certainly is, we're talking about the impact of COVID. The statistics bear out that 85, 90% of the fatalities have been people over 65 years old, I think. So it's had a disproportionate effect on older folks. From a software use and telehealth standpoint, what have you seen?
Go ahead.
Go ahead.
I was going to say, from the therapy perspective, we have had some older individuals sign on to our platform, and there has been a learning curve of just even getting them to download the app, getting them to be able to use the platform, go through some of the stretching exercises, things like that. Once they get on, a lot of times it's a family member that's engaging and helping them. The process becomes easier for them. I think the televisits, as far as from a physician standpoint, can be a little more difficult because it might be that 1 or 2 time visit of seeing the physician and really trying to get onto the system.
And I was going to say, one of the really important occupational therapy breakthroughs is that we get these people into the 21st century. We have IT support. We go out and upgrade their internet, and we make them, if not tech savvy, at least tech familiar with help. And I think that makes a huge difference. These people are isolated. And I think if you don't have internet now, it's like not having a telephone when I was growing up. You're cut off from the world.
Mm-hmm.
I'm pretty proud of my older population too. They, it's the learning curve, like Lisa was saying. Once you show them, though, they're so excited they can get on. They're like, "We're here!" It's kind of fun. Yeah, they're doing good. I haven't seen too much of a bend on that.
Well, my 87-year-old mother-in-law has been addicted to Facebook on her smartphone for about 4 years. So I know it definitely is something that can happen. Appreciate all the questions. We're at the top of the hour. I think there are a couple questions that we were not able to address. Carlos, hopefully that's something that we can get back with them in writing afterwards. But really appreciate, for the sake of time, to go ahead and close things out. The panel, y'all provided a great, unique and different perspective on things. And I think based on the questions we got from the audience, y'all definitely struck a nerve. If there's anything to take away, telehealth is here to stay. But the standard of practice and the best practices don't change just because you're delivering in a different mode. Carlos, with that, I will turn it over to you, sir.
Thanks, Mark. I appreciate that. Pertinent to any of the questions that were not answered by the panel this afternoon will be answered in writing. So we'll be sending those questions over to the panel to give some thought post this webinar, and then we'll be sure and circulate those answers to the group that attended the webinar today. So stay tuned for that. So if you have any questions that you did not have time to answer or to ask, rather, feel free to send it in through the chat. We'll get those answered offline. Once again, thank you to our distinguished panel, to Mark, Brooke, Lisa, Dr. Smith, and Dr. Gart, for taking the time to share not only your valuable insight, but to prepare. I know that putting on a webinar like this takes a lot of time, a lot of work, and so we're greatly, greatly appreciative of everything that you put into making today possible. We also want to thank Risico and IOH for making the event possible. And until next time, thank you to the audience for sharing your day with us and your experience with us. Again, if you have any follow-up questions, don't hesitate to send them our way. Have a wonderful day.
Thank you.
Thank you.